Shall we begin, sir?
Yes, yes.
Okay, sir. Greetings and a warm welcome to all the dignitaries present here. I am Rimpa from Clearnet, serving as an allocated session assistant to ensure a seamless experience. Clearnet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clearnet serve as the digital partner for this event, and the focus of today's session is anesthetic management of newborn. Now, I would like to invite Dr.AL.Meenakshi Sundaram, sir, a distinguished anesthesiologist and academic leader. Sir has served as Dean and DME at several government medical colleges, including Theni and Stanley Medical College, Chennai. He is a former national vice president of the Indian Society of Anesthesiologists and has held key positions including governing council member, president, and state secretary of the ISA Tamil Nadu State Branch. So, without further any delay, I would like to hand over the session to you, sir. Please proceed with your talk.
Thank you, Clement. So, usually we begin with the presidential address, but our president is preoccupied with the surgery, and he wanted me to inform only one thing. So, on behalf of our president, I wish to inform that Pudukkottai ISA City Branch is conducting a ultrasound guided nerve block workshop on May 31st in Hotel Ma Grand, Pudukkottai, followed by a CME on June 1st. So the faculties are from Kerala, Pondicherry, Karnataka, Andhra, Telangana, and Delhi. So we have invited 12 speakers, actually, 4 for workshop and 8 for lectures, CME lectures. So the flyers will come tomorrow. It is a short time only. So the viewers, please take note that Pudukkottai ISA is conducting a physical CME followed by that is ultrasound guided nerve block workshop followed by CME. Now I request our city branch secretary, Dr. Kannan, to for his secretary's report.
Good evening all. I am Dr. Kannan, Secretary ISA Puthukkottai City Branch. Successfully, we are conducting 16th webinar of second edition of Puthukkottai Bhudhan today. Today our topic is anesthetic management in newborn. I welcome all our eminent speakers and participating delegates to the webinar. Last week, 30th April, we have conducted our 15th webinar smoothly. Last webinar topic was anesthetic management in obesity. We have divided the topic into 3 subtopics. First subtopic is pathophysiology of obesity, and second subtopic is pre-operative assessment in obesity, and third subtopic is peri-operative management in obesity. First subtopic, pathophysiology of obesity, was done by Dr. Trapti Singh, Tirthankar Mahavir Medical College and Research Institute, Uttar Pradesh. And second subtopic, pre-operative assessment in obesity. This topic was done by Dr. Muhammad Sabas Alam, Tirthankar Mahavir Medical College and Hospital, Uttar Pradesh. Third subtopic is perioperative management in obesity, was done by Dr. Payal Jain. Our moderator was Dr. Mukesh K. Prasad. Last webinar was attended by 980 delegates. Academic faculties, kindly encourage your postgraduates to attend our webinar continuously, which are very useful for their exams. And our academic chairman said we are going to conduct workshop on May 31st and CME on June 1. All delegates kindly participate in our CME. Thank you all.
Thank you, Mr. Secretary. And now it is my duty to inform the faculty. At the outset, I want to inform all the people. I have even messaged that ISA Pudukkottai City Branch expresses its solidarity, support, and appreciation for Mother India for the retaliation against the terrorist attacks in Pahalgam. And now there is an anticipatory blackout in the state of Madhya Pradesh between 7:30 to 7:45. So delegates, please note, we have advanced the timings only for that. So at the end of all the 3 lectures, there will be a discussion subject to the availability. So if there is a blackout, even they will try to change to the mobile mode, but I request all the people to be aware of that. So without wasting much of a time, I want to inform this youngest faculty Dr. Aishwarya Pramod, Meempat, to be precise. She has done MBBS from Kerala. Now she is doing her dependent anesthesia in the CHL hospital Indore. And to her credit, she has won the first prize in Dr. M.T. Bhatia PG research paper presentation, and she was appreciated in the National ISA conference. And she is interested in dancing. So actually, her spouse will dance to her tunes, and she will dance on her own. So we welcome the youngest faculty, Dr. Aishwarya, for this Pudukkottai Bhudhan, and it will
Thank
be.
you, sir.
Thank you very much. Thank you very much. And Madam, next the lecture will be followed by Dr. Meenu Chadha Madam. Chadha Madam is popular. If you say Chadha Madam, she is popular throughout the country and as well as internationally. We need not inform Meenu also. And Madam is smiling here, but she is strict disciplinary and everyone will be afraid of mentioning her name because we have seen the conference organized by her. She was the scientific committee chairman in Indore. And even today, that Indore conference is the best conference we have ever attended. Even though it was conducted in a temporary sheds, everything was planned. And Madam, as a scientific committee chairman, crafted the scientific topics in a very good way. And she run the session as per schedule. So you cannot find out any mishap in that, no, not even a simple slip. So these people with the organizing secretary and all the people, Madam has given a united front and that is her success and such a great personality. When we are conducting this Pudukkottai Bhudhan weekly webinar, Madam graciously offered to conduct a webinar and we are very happy. Madam has arranged all the other three speakers. So we thank her very much and her academic prowess will be seen while she is delivering. That too, she is ready to deliver on the fluid balance, which is a very difficult chapter. And it will be followed by Dr. Yash Mehta. He is a UACON person. So in UA conference, he used to chair the session. He used to deliver lectures and he is a RSACP member also. And right now, Madam is organizing a national conference on RSACP. So it will also be successful like a Indore ISA conference. And Yash is one of the members and a colleague of Madam. And he is an organizing committee member of Indo ISACON. And he has presented papers, even poster presentation in the UACON and ISA conferences. And to moderate this session, we need Dr. Mayank. Even now, sir is in a case. So that shows the sincerity of anesthesiologist. Even I said, just like a military protects us, we remain vigilant. To sleep peacefully, you need a person to be vigilant. And we are sleeping because the army is vigilant. And the patient is sleeping in the operation theater because anesthetist is vigilant. In spite of that, in the theater attire, he is appearing for that. And probably that may be the reason even postgraduate is in the theater dress. So they are dedicated to their work. And Dr. Mayank is a senior consultant. Just now he has changed his hospital to Jupiter. So he's interested in onco anesthesia. That is a very rare specialty people will take. And he is interested in photography and his hobby is reading. So Sar has to show his face. He has to switch on the video and he has to take a screenshot because he's a good photographer. So that we will keep it for our reference. Thank you, sir. Now I hand over the session to Dr. Mayank, sir.
Kind words that you have given to me. Thank you so much. And let us begin with the webinar, which is a very important topic of a newborn child. Pediatrics is always a very challenging topic for the anesthesiologist, and extremes of age are very difficult to deal with. So in this particular webinar, we'll be speaking about the three important topics, which will be delivered by good speakers. So please be attentive and attend the webinar in full flow. The questions will be taken at the end. Thank you so much. Over to Aishwarya.
Good evening, everyone. Thank you, sir, for the kind introduction. So we'll start.
Aishwarya,
ma'am.
yeah, full screen. Okay.
So we'll start with the topic of neonatal airway and anesthesiologist perspective. So today's goals of today's presentation, mainly to differentiate the differences between neonatal and adult airway and the neonatal intubation technique and equipments used and the common mistakes that can happen and the complications during the neonatal intubation. So neonates are not small adults. So we shouldn't consider neonates as a smaller version of adults. No, they're entirely different. Their anatomy and physiology both are entirely different. So starting with the morphology of their head, they have a large occiput. So the problems that we can come across is during the position for intubation. Large occiput can give us difficulty during the securing the position for intubation. And they have thin, hollow, underdeveloped mandible. So that can give us problem during securing the mask for a bag and mask ventilation. And they have a floppy omega shaped epiglottis, which can give us difficulty in laryngoscopy and intubation. And they have a narrow subglottic area, and they have a high anterior larynx and large trunk and narrow nares. So starting from the nares of the pediatric airway, so they have smaller nares and they are obligate nasal breathers, and their palate is not ossified, and they have a larger tongue compared to that of an adult. And all the cartilages in the newborn, it is very soft, and we should be very careful while giving a cricoid pressure because we can produce trauma to those cartilages. And a very significant difference is that they have a subglottic funneling. So this feature is not there in the adult larynx. So in adult larynx, the narrowest part of the larynx is the vocal cord, true vocal cords, whereas in the pediatric or neonatal, this narrowest portion is the subglottic area. So this is because of the subglottic funneling. So coming to the anatomical differences, it can be supraglottic and subglottic. So now telling about the supraglottic differences in the anatomy. So nares, mainly it is neonatal, it is narrow, and angle of jaw is obtuse, and tongue size is larger, palate is non-ossified, whereas it will be ossified in an adult, and epiglottis is large, floppy, more cephaloid, and the position of the larynx. In newborn, it is at the level of C3, and at the age, by the age of 6 years, the position will reach up to C4, C6 vertebra, and whereas in the adult, the position of larynx is C5 to C6. And the description of larynx is more anterior and cephaloid in that of a neonate, and the vocal cords are more anterior and slanting. And when coming to the submucosal tissue of the airway, they are more. So there are more, since the submucosal tissue is more, there are more chances of edema. So here you can see, in case of an adult, the average diameter of the airway will be 8 millimeter, whereas in that of an infant will be 4 millimeter. So even a 1 millimeter of an edema can cause significant reduction in the airway diameter and can cause significant airway obstruction in case of an infant, whereas in adult 1 millimeter of mucosal edema will not cause much airway obstruction. And coming to subglottic anatomical differences, as already mentioned, cartilages will be soft and collapse easily, so you should reduce the cricoid pressure, and lumen will be narrow, circular, whereas in case of an adult, it will be wide and elliptical. And the subglottis will be funneled, and the narrowest part is subglottic area, and the tracheal length in neonate is 4 centimeter, whereas in adult it is around 10 to 12, 10 to 15 centimeters. And angulation of bronchi is more horizontal in that of a neonate, whereas it is less horizontal in that of an adult. And the diaphragm is higher, and you can see you won't get that classical bucket hand movement of the ribs during inspiration expiration in neonates, whereas in neonates you'll be having a piston movement, whereas in adult you can see that bucket handle movement. And alveoli lesser in number, 20 to 50 million in neonates, whereas in adult it is more, 300 million. And the physiological differences are they are mainly obligate nose breathers. So you should be very careful while passing anything through the nose, because nasal bleeding can be very detrimental to them because they don't know how to breathe through the mouth. And they have increased airway resistance because once they are inside the mother's womb, all the oxygenation is taking place through the placenta. So once they take the first breath, then only the pulmonary pressures, everything comes down and the lungs start functioning. So in a neonate, they still have increased airway resistance, So you should be very careful by positioning the head, and you have to minimize the apparatus resistance so that to facilitate proper ventilation. And there will be already increased dead space because the baby is only starting to breathe and use the lungs. So there will be increased dead space also. So we have to use circuits with low dead space and use RBS, Rendell Baker Sosek mask, which is an anatomical mask, and it is designed in such a way that it covers all the dead space. It reduces the dead space so that we can give adequate ventilation by reducing the dead space. And surfactant appears at around 28 weeks, so that if we are dealing with a baby of less than 28 weeks, we should be careful that the babies can be having respiratory distress syndrome. And they have a narrow caliber of airway, so they can have increased work of breathing, and cartilages are soft, and they have reduced functional residual capacity and lung volume. So everyone would have observed it in the operation theater itself. Babies desaturate very rapidly. Even within seconds of hypoxia, they desaturate very rapidly. That is because one thing is they have reduced FRC and lung volumes, and they also have increased alveolar ventilation. That is 100 ml per kg per minute of alveolar ventilation, and their increased basal metabolic rate also. And the lung elastic tissue is poorly developed, and their compliance is also reduced, and they have lesser number of alveoli. So we have to provide them with a higher respiratory rate. So compared to an adult, a neonate is always having a increased respiratory rate. Why? Because their lungs are less compliant and they have lesser number of alveoli. So to maintain the adequate oxygenation and adequate oxygen supply to the tissues, we have to provide them with a higher respiratory rate. And they have poor respiratory mechanics. They have increased alveolar ventilation. So this increased alveolar ventilation can also contribute to rapid emergence from the volatile inhalational agents. And they've increased closing volume compared to adults, so they can have more air trapping. And while we are using oxygen and nitrous as the inhalational agents, they can have absorptive atelectasis. So it is better to use oxygen and air mixture below 3 months of age. And they have a very immature respiratory center because all the centers CNS is yet to develop, so very sensitive for depressants. And they have lower PO2 values, 50 millimeters of mercury for term neonate and 75 millimeters of mercury after 1 week. Okay, so now coming to the main topic as such, indications for intubation. So why are we intubating a newborn baby, and what are all the indications? So it can be it can be in the delivery room, and other it can be in the NICU. So in the delivery room, it can be along with the neonatal resuscitation. So during the cardiopulmonary respiratory instability, and during meconium aspiration with a depressed infant, or prematurity requiring need for surfactant therapy, or congenital malformations. And in the NICU, the indications are unable to protect the airway, or hypercarbic respiratory failure, hypoxic respiratory failure, or any therapeutic indications. So you have to see a basic checklist before newborn intubation. So the monitors have a routine monitors like ECG, end-tidal carbon dioxide monitoring, temperature monitoring, and pulse oximeter. And always make sure that a suction catheter and suction apparatus is ready, and the machine ventilators, bag, mask, laryngoscope, stillets, and airways of appropriate size, endotracheal tubes of appropriate size, and intravenous lines, peripheral and central lines to be kept ready, and drugs, sedation, analgesia, muscle relaxants, or atropine. So coming to laryngoscope blades, straight blade Miller or curved blade Macintosh can be used. While we are using the straight blade, always make sure that the tip of the blade goes below the epiglottis. So you have to, the tip of the blade should go below the epiglottis and lift anteriorly to visualize the vocal cord. Whereas if you are using a curved blade like Macintosh, the tip of the blade should go above the epiglottis. That is in the vallecula, and you have to lift anteriorly to visualize the vocal cords. And the endotracheal tubes, they are divided by their size of the internal diameter. So for neonate, it is a general rule that the endotracheal tube size is roughly corresponds to 1/10 of their gestational age in weeks. So for example, a 36-week preterm would get a 3.53 around size of endotracheal tube, whereas 28-week preterm would get a 2.5 millimeter sized endotracheal tube. So intubation procedure, you should have a proper positioning of the baby. Since they have a large occiput, they can give a difficulty in providing the procedure. So bed and patient should be at a comfortable height to the anesthesiologist, and section and meconium aspirator should be readily available. Endotracheal tube, stillet, airways, breathing circuits, and laryngoscope should be ready, and all this equipment should be tested prior to usage. So ideally keep a shoulder roll and head in a sniffing position, and make sure that you are not hyperextending the head. That's hyperextension can actually make visualization difficult. And always pre-oxygenate with 100% bag wall mask ventilation, and it is contraindicated in congenital diaphragmatic hernia. And apply the monitor before pre-oxygenation, and give drugs. Remember, minimum atropine dose should be readily available. Then ensure ability of bag, mask, ventilate before administering muscle relaxants. So make sure that you are able to bag and mask the patient before giving muscle relaxants. Okay, so the intubation procedure, inserting the laryngoscope blade, as I already mentioned, hold the laryngoscope in the left hand, and while standing above the patient, insert the blade in the right side of the mouth, and you shouldn't be in a hurry to visualize the vocal cord. Take time and insert it, and push this tongue to the left side, and lower your head to the level of the OT table. You can see that in the picture how that lady is doing, and slowly advance the laryngoscope until you visualize the epiglottis. So you should not be in a hurry. You should slowly advance it further until you see the epiglottis. And as mentioned, use straight or curved blade appropriately to lift the epiglottis. And you can see the codes. This is the valvular root of tongue and valvular area. If you are using a curved blade, you have to put the tip in that valvular area. Whereas if you are using a straight blade, you should go below the epiglottis and lift it. Okay, so you have to, once after visualizing the vocal cord, you have to insert the endotracheal tube and secure the airway. And how can you confirm whether we have intubated the trachea or the esophagus? One, you can directly visualize, and then end-tidal carbon dioxide monitoring, chest rise you can see, and auscultation, and through chest X-ray. So after inserting, you have to secure the endotracheal tube with a tape, and after securing, you have to recheck whether there is adequate chest rise, or whether the ventilation is proper, because many a times it can happen after securing, it can come out, it can dislocate. And the common problems while intubation is that esophageal intubation. So to prevent that, it can occur due to blade placed too deep and course not visualized, and blind intubation. And tongue can obscure visualization because they have a comparatively larger tongue. So to overcome that, sweep tongue to one side with blade and give a more anterior lift. And if you cannot see the codes, adjust the position of the head. In cannot intubate situation, always call for help. And even if you can't intubate the patient, continue providing oxygenation through bag and mask. And last resort will be surgical airway. So difficult neonate airways are abnormalities in the airway, congenital abnormalities that there can be. Then things you can see, and there are things you may find. So things you can see is usually that we can predict by seeing the morphology of the baby, like cleft lip and palate, peri-Robin syndrome, Treacher-Collins syndrome, golden heart syndrome, upper tongue corrosion syndrome. These are the common syndromes that are associated with cleft lip palate surgeries that are usually done in neonates. Then difficult neonatal airways, we can see laryngomalacia. We may find while in laryngoscopy, we can find laryngomalacia, hemangioma or lymphangioma, tracheal web, laryngeal atresia, subglottic stenosis. All these things we cannot see them, but you may find them during laryngoscopy. So these are the congenital malformation: cleft lip palate, peri-Robin sequence, then upward corrosion syndrome, golden hair syndrome, Treacher-Collins syndrome babies, Down syndrome babies, and you can see laryngomalacia, different grades of laryngomalacia. Then laryngeal web can be seen. There can be tracheal atresia, and these babies survive only if there is a presence of tracheoesophageal fistula or emergent tracheostomy. Then congenital malformation like hemangioma or lymphangioma, then subglottic stenosis. So summary, proper positioning is critical for successful neonatal intubation, and call for help early if unable to intubate, or for any congenital anomalies, and continue to provide oxygen with bag valve mask ventilation. Practice makes man perfect, and it is estimated that you need to perform at least 90 intubations to be able to intubate successfully on the first or second attempt at least 80% of the time. Thank you.
Dr. Mayank, sir. So I will take his role for time being. Dr. Aishwarya has deliberated at length, and what we wanted to have, she has given every necessary points, even from anatomy and physiological differences. She has given everything, how to intubate, even if she has given a picture. I think she can prepare a video while she intubates the newborn. So madam has to help, so that will have more weightage, that when you are doing that, so that how the shoulder support is given, how the padded is kept, so everything will be good. And now there is going to be followed youngest speaker to the most skillful academician. Dr. Chadha madam is going to talk about the fluid balance. Please, madam.
Thank you, Dr. Meenakshi. Perioperative fluid therapy in the newborn. Now, perioperative fluid management in the newborn is a critical aspect of care, especially in children who are undergoing surgery. Now, this is what I would be covering in this lecture: a word about neonatal physiology, fasting guidelines, intraoperative fluid management, postoperative fluid management, and electrolyte imbalance, and composition of IV fluid. Sorry, the pictures were coming on this side. Now, why is this fluid management important in neonates? Now, as Dr. Aishwarya has already said, that neonates, they are not small adults. The physiology, anatomy of both the newborn and adult is very, very different. All of them don't need the same IV fluids, either in quantity or composition. Perioperative fluid management in a neonate can be very challenging. If you give an overzealous fluid administration, there can be an increased mortality. While if you give a less fluid, then the patient can develop hypotension and can develop acute kidney injury. So if the wrong fluids are given, the neonatal physiology is not well equipped to handle them, and serious morbidity can result from fluid and electrolyte imbalance. Now, how is this neonatal physiology different? There is a transition from fetal life to neonatal life. It involves significant changes in the body water depending on the gestational age and the stage of cardiorespiratory adaptation. Now, we can see that there is a lot of difference in adults and the neonates in the amount of water the body has. Adults have about 60% of water, out of which 20% is in the extracellular fluid, while 40% in the intracellular fluid. The term neonates have 75% water, of which 40% is extracellular and 35% intracellular. And preterm neonates, especially at 23 weeks, they are 90% of water, out of which 60% is extracellular and 30% is intracellular. Now, this just is a brief chart which shows us the amount of water in the body. As you can see in the preterm, there is a lot of water, more than 80%, about 90% water. And this decreases as in a term. And by the child becomes an adult, both the water and the muscle mass, they become almost the same. So what happens in the postnatal period? Now, in the normal conditions, in the first few days after birth, the postnatal increase in the capillary membrane integrity, this favors the absorption of the interstitial fluid into the intravascular compartment. As a result, what happens is there is a release of the atrial natriuretic peptide from the heart. And this enhances the renal sodium and water excretion, causing a decrease in the total body weight and weight loss. Though it is considered that most of the postnatal weight loss is due to contraction of the extracellular fluid compartment, but especially in the extremely low birth weight baby, this may be due to the increased transepidermal weight loss also. Now, this high water content, it provides a large volume of distribution for the water-soluble medications. This has very great anesthetic implications because the water-soluble drugs, they have a larger volume of distribution. and so require a much dose, especially of antibiotics and muscle relaxants. Drugs which depend on the redistribution into the fat, they have longer clinical effects such as thiopental, and drugs redistributing into the muscle, they have a longer clinical effect, that is fentanyl. So what happens after birth? There is an efflux of fluid from the interstitial fluid to the extracellular fluid. Now, what this causes is that there is a flood of it floods the neonatal kidney and results in the salt and water diuresis, which occurs in 48 to 72 hours. Now, this extracellular fluid compartment loss is much more in the preterm neonates than in the term neonates, because we have seen that the water content of the preterm is much more than the term baby. So this results in the physiological weight loss in the first week of life. Now, this weight loss is much more in the preterm. It is about 10 to 15%, while in the term, it is about 5 to 10%. And failure to lose this extracellular fluid volume may be associated with morbidities like patent ductus arteriosus, necrotizing enterocolitis, or chronic lung disease. Now, further, this weight loss, it reaches its nadir at about 5 days and tries to come back to normal by about 7 days, while in the preterm baby, it takes a much longer time to return to the normal birth weight. Now, what happens to the kidneys? The neonatal renal physiology, there's a decreased GFR. Now, this is because of the decreased mean arterial pressure and the increased intrarenal and a high intrarenal vascular resistance. Now, as the age of the child rises, the GFR begins to rise because of the increase in the mean arterial pressure and decrease in the intrarenal vascular resistance. There is also a decreased ability to concentrate urine. This is because of the shorter loop of Henle and a reduced tonicity of the medullary interstitium. As a result of which, the limited ability to produce the concentrated urine causes a much greater dehydration in the child. Further, there is prematurity of the renal tubules, which is associated with the reduced capacity to absorb sodium from the distal tubules. The effective renal blood flow is as low as 20 ml per minute in a premature infant, and while in the 35 weeks, it can be 45 ml per minute, while in the term baby, it increases to about 83 ml per minute. Now, let's look at the heart. The infants are more sensitive to hypovolemia due to the relatively low contractile mass per gram of the cardiac tissue and limited ability to increase the myocardial contractility. The neonatal heart is basically less compliant, and it is more dependent on the heart rate to increase the cardiac output. There is also a decrease in the ventricular compliance, and there is an extremely limited ability to increase the stroke volume, which is needed to increase the heart rate and increase the cardiac output. This is known as the Treppe effect. Understanding the neonatal cardiovascular physiology is very, very important, because you have to be aware of the post-operative complications that can occur, such as persistent pulmonary hypertension or certain congenital heart defects. Now, what happens to the neuroendocrine system? In the first few days, the ADH concentration are high and the renal water losses are low. In the neonates, the hypoxemia, acidemia, volume depletion, sepsis, etc., they act as a stimulus to the ADH release. Therefore, fluids are often restricted after surgery. The aldosterone secretion is slow to respond to the high sodium load, so sodium is excluded until postnatal diuresis occurs, that is after 48 to 72 hours. And after supplementation of sodium, it is very important to avoid hyponatremia, as the renin-angiotensin-aldosterone system, it has a limited capacity to retain sodium because the renal tubules are partially unresponsive to aldosterone. Now, another important thing in the neonatal physiology is the insensible water loss. Now, this insensible water loss is much more in the preterm than the term babies because of the increased body surface area compared to the body weight ratio. This is because of the increased respiratory rate, certain surgical malformations which can occur, such as gastrochasis, omphalocele, or neural tube defect. Increase in the body temperature. It is found that the insensible water loss increases by 30% per degree centigrade rise of temperature. Further, a rise in the ambient temperature also causes 30% increase in the insensible water loss per degree rise in temperature. Use of radiant warmer and phototherapy, it causes a 50% increase in the insensible water loss, decreased ambient humidity, and increased motor activity such as crying can also increase the insensible water loss by about 50 to 70%. Now, how can this insensible water loss be decreased? This is by the use of incubators, humidification of the inspired gases in head box and ventilators, use of plexiglass head shields, increased ambient humidity, thin transparent plastic barriers, which reduce to 30% of the insensible water loss. What is the importance in the anesthesia is you have to cover the neonate properly. Some centers recommend that they can be covered with a plastic film or a plastic shield so that the temperature is maintained. And it is very important to keep the OT temperature high so that the child doesn't suffer from hypothermia. Now, let us just look at the insensible weight loss according to the birth weight on day 1. If the child neonate is less than 1000 grams, then the insensible water loss is 60 to 80 ml per kg per day. In 1000 to 1500, it is 40 to 60 ml per kg. And more than 1500 gram, it is about 20 ml per kg per day. Now, what about the pre-operative fluid? Now, the most important thing is the fasting guidelines. The earlier guidelines, they said that if the neonate is less than 6 months, it was 4 hours for milk and solid, and for clear liquid, it was 2 hours. For 6 to 36 months, it was 6 hours, while it was 3 hours for clear liquids. And in a child more than 36 months, it was 8 hours for milk and solid, and for clear liquid, it was 3 hours. But the European Society of Anesthesia has come up with the guidelines, newer guidelines in 2011, and they said that 2 hours for clear liquids and 4 hours for breast milk, 6 hours for non-human milk or infant formula, and 8 hours for solid food. The advantage is that it prevents dehydration and hypoglycemia and reduces the risk of aspiration. So fasting, it helps in giving safe anesthesia, because if the child is not taking anything orally, then the chances of aspiration are reduced. Now, after the preoperative fluid, let us come to the intraoperative fluid therapy. Now, this intraoperative fluid therapy can be divided basically into 3 parts: the deficit therapy, the maintenance therapy, and the replacement of the third space and the blood loss. In general, any child or a neonate undergoing elective surgery should be very well hydrated before surgery. Now, this is made possible by the new fasting guidelines. And even in a child who's not taking orally or taking any liquids or breast milk, what you have to do is that the IV fluid has to be started pre-operatively so that the child is not dehydrated pre-operatively. And if you detect signs of dehydration, then it is recommended that you give isotonic glucose-free fluid about 20 ml per kg over 10 minutes to prevent this dehydration. Now, this deficit therapy is to compensate for dehydration or fasting, maintenance therapy to compensate for loss due to insensible water loss, and replacement therapy, as we have said, is due to blood loss and the third space loss. Now, how do you assess this fluid and the electrolytes? Now, first of all, it is the history, which is very important. You have to ask the mother of what the child has taken. Then second is the physical examination. Weight of the child is very important. If the child is not in the first week after birth, then there should be no weight loss. Because as I have said earlier, that in the preterm babies, the weight loss is about 1 to 3% of the original weight per day, and to the maximum of 15%, while in the term neonate, it is about, it is 2 to 5% in the preterm, and it is 1 to 3% in the term babies in the first week of life. And other important criteria is the skin, mucosa, altered skin turgor, sunken anterior fontanelle, dry mucosa, edema, etc. There might be tachycardia, delayed capillary refill, hepatomegaly can occur, while blood pressure changes, they occur very late. So this is just a chart which shows us the clinical signs of mild dehydration and moderate dehydration and severe dehydration. If the child is mildly dehydrated, that is less than 3% of the weight loss, the child may be alert and restless, while rest of the things are normal. So the estimated deficit is about 30 to 50 ml per kg. In moderate dehydration, that is 3 to 10%, the child is thirsty and lethargic. The pulse will be rapid and weak. Respiration will be deep and rapid. Systolic blood pressure can be normal or low. There will be a reduced urine output, dry mouth, sunken eyes, sunken fontanelle. The skin turgor will be reduced. There may be a slight capillary refill, may be prolonged 1 to 2 seconds. Child may be a little drowsy, and the deficit is about 60 to 100 ml per kg. In severe dehydration, that is more than 10%, the child is cold, sweaty, limp. The pulse may be rapid and feeble. Respiration will be deep. BP may not be recordable. The output will be reduced. There will be dry mouth, sunken eyes. Fontanelle will be very sunken. The skin will be cool and mottled. Capillary refill will be more than 2 seconds. Child will be very drowsy, and the estimated deficit is more than 100 ml per kg. Now, there are certain laboratory tests that also you can do. Serum electrolytes, especially the serum sodium, is very, very important. The normal serum sodium should be about 135 milliequivalents per liter, and the plasma osmolarity is also very important. Now, if the child has hyponatremia with weight loss, it suggests sodium depletion and would merit sodium replacement. If there is hyponatremia with weight gain, it suggests water excess and you should have fluid restriction. If there is hypernatremia with weight loss, it suggests dehydration and would require fluid correction over 48 hours. And if there is hypernatremia with weight gain, then it suggests salt and water load is more, and it would indicate a restriction of the fluid and the sodium load. Urine output, the normal urine output should be about 1 to 3 ml per kg with the osmolality of 1.005 to 1.012 with a specific gravity, The urine electrolytes and specific gravity is also measured. Blood urea and serum creatinine, they are measured to indicate any kidney injury. ABG can be done, but only at a very later stages, and it only when you are suspecting some amount of acidosis. So what is your goal? Your goal is to allow the initial loss of extracellular fluid over the first week, which is reflected by the weight loss, while maintaining the normal intravascular volume and tonicity, which is reflected by the heart rate, urine output, electrolytes, and the pH. Subsequently, maintain the water and the electrolyte balance, which is needed for body growth, and individualize the approach according to the response of the child and the age. So how do you calculate the deficit due to fasting? It is in the elderly child, it can be based on the holiday cigar, that is 100 ml of water for 100 calories expended. That is 4-2-1 rule. The child's response to fluid therapy should always be monitored. Hourly maintenance requirement into hours of fluid restriction, 50% is given in first hour and 25% is given in the next 2 hours. If the child is less than 10 kg, then it is 4 ml per kg. 10 to 20, it is 40 ml plus 2 ml per kg, about 10 kg. And more than 20 kg, it is 60 ml plus 1 ml per kg, about 20 kg. This is the maintenance fluid in the neonate. If the birth weight is less than 1000 grams, on day 1, it is 80 ml per kg per day. and it increases to 160 ml per kg per day by day 7. In 1000 to 15, it also starts with 80 ml and increases to 150 ml. And more than 15, it starts with 60 ml per kg and increases to 150 ml. Now, why is this fluid necessary? Hypoglycemia is very common in children. Not in children, in neonates. The risk factors are the prematurity, perinatal stress or asphyxia, being small for gestation age, and maternal diabetes. So neonates receiving parenteral nutrition or IV fluids, even if this is stopped prior to anesthesia, the child can develop hypoglycemia. So it is very necessary in small neonates or preterm babies to give dextrose. So what is the choice of fluid in term babies or babies with a birth weight more than 1500 gram? On day 1, it is 10% dextrose to maintain a glucose infusion of 4 to 6 milligram per kilogram per minute. And day 2 to 7, it is 10% dextrose with sodium and potassium to be added after 48 hours. That is, after the diuresis has occurred, then only you can add the electrolytes to it. In preterm babies with a birth weight of 1000 to 1500 grams, on day 1, it is 10% dextrose. Day 2 to 7, it is 10% dextrose and sodium and potassium to be added after 48 hours. After day 7, the fluid is given at the rate of 150 to 160 ml per kg per day and sodium supplementation at 3 to 5 milliequivalent, and it should continue till 32 to 34 weeks corrected gestational age. Now, what is the maintenance fluid? The maintenance fluid used during the surgery, it should be isotonic. Earlier, it was advocated that you use hypotonic solutions, but that causes a lot of hyponatremia. So these are not indicated nowadays. You can use isotonic solutions such as 0.9% sodium chloride or ringer lactate or Hartmann solution. And especially in the preterm or term babies, you can add some amount of dextrose to it to make a concentration of 1 to 2.5%. Now, these solutions with premixed with dextrose are not available, but you can add dextrose to it, or you can give dextrose by an infusion pump separately. So neonates in the first 48 hours of life should be given dextrose during surgery, and the maintenance fluid is calculated by the holiday SEGAR for patients more than 4 weeks of age. Now, the maintenance fluid on a newborn on term day 1 is 50 to 60 ml per kg per day of dextrose 10%. On day 2, it is 80 ml per kg per day of dextrose 10%. While on day 7, it is 100 to 150 ml per kg, either 5% dextrose or 10% or 1/4 normal saline. While in older child, you follow the 4, 2 and 1 rule. Why is this glucose important in the perioperative period? This is because they lack the glycogen store. Hypoglycemia is very commonly encountered, especially in term and preterm babies. Response to anesthesia and surgery may sometimes cause hyperglycemia, and so can anxiety and pain. This hypoglycemia can cause deleterious effects such as brain damage, while hyperglycemia can result in osmotic diuresis leading to dehydration and electrolyte imbalance. Exception to this is neonates in the first 48 hours of life, preterm and term infants already receiving dextrose-containing solution, children on parenteral nutrition, children of low body weight or having prolonged surgery, and children with diminished sympathetic response to regional anesthesia. Now, the replacement fluid. Now, this has to be given to compensate for the third space loss and for the blood loss. Third space loss, traditionally third space losses, they were replaced with the crystalloid solution between 1 ml per kg per hour for minor surgical procedures, and then can be increased to about 50 ml per kg per hour for major surgeries in the premature infant. But the concept of third space loss is still very debatable. Now, let us look at the blood loss. For calculating the blood loss, first of all, we have to know how much blood volume is there. In the premature neonates, it is about 95 to 100 ml per kg. In full-term neonates, it is 85 to 90 ml per kg, while in infants, it is 80 ml per kg. Now, how can you calculate the blood loss? It is by knowing both the estimated blood volume and the maximum allowable blood loss. So how do you calculate this estimated blood volume? It is weight in kg into average blood volume. So suppose the child is about 5 kg, the average blood volume will be 80 ml per kg. So the estimated blood volume would be 400. And then you can calculate the maximum allowable blood loss, which is the estimated blood volume into initial hematocrit minus the target hematocrit divided by the initial hematocrit. Now, why is there need of transfusion in these such small children? The Canadian guidelines recommend that the neonate should be transfused in situation where there is acute blood loss that is more than 10% of the circulating blood volume. The hemoglobin is less than 8 grams per DL in a stable newborn with the symptoms of anemia such as apnea, bradycardia, tachycardia, or poor weight gain, or hemoglobin less than 12 gram in infants with respiratory distress syndrome or congenital heart disease. Platelets. Now, these neonates, they may be sick, and certain sick neonates, they may also have some severe thrombocytopenia. So what is the cutout for this platelet count? It is 1 lakh. And platelet for neonatal transfusion should be just like an adult. It should be ABO identical or compatible and RHD identical or compatible. Cytomegalovirus negative, produced by single donor apheresis and infused in a volume of 10 to 20 ml per kg. Fresh frozen plasma. There is uncertainty about transfusion triggers for fresh frozen plasma in the neonates. The guidelines recommend that it can be used for vitamin K deficiency with bleeding, DIC, or congenital coagulation deficiency when no other factor concentrate is available. The dose is 12 to 15 ml per kg. Now, post-operative fluid management. Neonates with the surgical conditions, they are exposed to a greater risk of dehydration. This is because of the reduced intake, increase in the requirement or losses, and inadequate replacement. These babies are usually nursed in the open care system and repeatedly exposed for examinations and for dressings. Further, they are transferred a lot of time to the radiology units also. So repeated exposures are there, which can lead to increased dehydration. So this is needed to avoid dehydration and to correct hypovolemia. The composition of fluid to be administered should compromise between sodium, energy requirement, that is, it should have some amount of glucose, and the osmolarity. You have to beware of the hidden fluid administration, because many times you give antibiotics, these can be diluted in 10 ml of fluid or 20 ml of fluid. So that much amount of fluid is going into the neonate, which may sometimes lead to excess fluid and may cause increased morbidity and mortality. Monitoring of serum sodium and glucose in a sick patient should be done at least once daily. Now, electrolyte imbalance in the perioperative period. Now, there are two important electrolytes that we would look at: serum sodium and the potassium. The daily requirement of serum sodium is 2 to 4 milliequivalent per kg per day. And positive pressure ventilation and PEEP causes natriuresis and water retention. The daily requirement of potassium is 2 to 4 milliequivalent per kg per day. The hyponatremia is the most frequent electrolyte disorder can occur when sodium is less than 135 milliequivalents per liter, and the most common cause is administration of hypotonic fluids, or patient may have other congenital malformation. So it is recommended that hypotonic fluid should not be used for post-operative maintenance. The early signs of hyponatremia, they are quite non-specific. The first presenting feature may sometimes be a seizure or a respiratory arrest, especially if the serum sodium goes below 125 milliequivalents per liter. It becomes a medical emergency. You have to shift the child to the PICU. The hyponatremic seizures may occur, which respond poorly to anticonvulsants. The initial management is to give an infusion of 3% sodium chloride solution, and 1 ml per kg of 3% sodium chloride will normally raise the serum sodium by 1 millimoles per liter. Now, the amount of sodium required can be calculated according to the formula. Millimoles of sodium is equal to 130 minus present serum sodium into 0.6 into weight in kg. The targeted rate of correction is about 0.5 milliequivalent per liter per hour, and rapid treatment should not be done because it can result in pontine myelinosis, and correction should be stopped if the child is asymptomatic or the serum sodium becomes more than 125 milliequivalent per liter. The child with an asymptomatic hyponatremia does not require correction with 3% sodium chloride solution. Hyponatremia can occur when serum sodium is more than 150 millimoles per liter. Replacement is with 0.9% sodium chloride given in a bolus of 20 ml per kg. It is given very slowly and the correction is done in 48 hours. And in hypervolemic hyponatremia, diuresis followed by replacement with hypotonic fluids. Potassium. The normal serum potassium hypokalemia can occur if the potassium is below 3.5 millimoles per liter. And in severe cases, the IV correction is done, but not faster than 0.25 milliequivalents per kg per hour to a maximum of 0.5 milliequivalents per kg per hour. Hyperkalemia can occur if the serum potassium is more than 5.5 milliequivalents in infants and more than 6 milliequivalents in neonates. You can treat it by giving 10% calcium gluconate, 100 milligram per kg per dose. This causes increase the intracellular shift to potassium by giving sodium bicarbonate 1 to 2 millimoles per kg or glucose 0.3 to 0.5 gram per kg per hour with 1 unit of insulin for every 5 gram of glucose. You can also do nebulization with salbutamol 2.5 to 5 milligram. Now, these are the commonly used IV fluids and their composition which are used in the neonates. Dextrose, as we can see, is the fluid which is used in the preterm and it is very commonly used. The indication is any infant requiring maintenance fluid for whom parenteral nutrition is not indicated. Initial management of persistent hypoglycemia unresponsive to increased enteral feeding. Sometimes even more than 10% is required. When it is unresponsive to 10% dextrose, a concentration of less than 12.5% can be given via peripheral cannula. You calculate the high glucose concentration using 5% and 50% glucose calculator. 5% can be used to supplement IV fluids with the aim of keeping the total glucose load within normal limits and as a diluent for common drug infusions. Now, the biggest question is hypotonic versus isotonic fluid. Which fluid do you give to these neonates? The fluid of choice varies and it depends on the pathophysiology in a surgical neonate. In a normal neonate, hypotonic maintenance fluid can be recommended, while in neonates and preterm infant, it is essential to calculate and replenish the preoperative fasting deficit with balanced isotonic solution with 1 to 2.5% of glucose. For preoperative resuscitation, you can give isotonic crystalloid as a bolus of 10 to 20 ml per kg over a short span of 10 to 15 minutes. And this may be repeated with 2 to 3 aliquots, depending on the hemodynamics and the urine output. Colloids. The colloids do not have much role in these neonates. Only 5% albumin is used preferentially because it is isoosmotic to plasma. But it can have deleterious effect, especially in conditions with increased capillary permeability like prematurity, sepsis, respiratory distress syndrome, and immediate postoperative period. And it may be counterproductive in increasing the tissue edema, which may occur when albumin leaks from the leaky capillaries and causes an increase in the oncotic pressure in the interstitial space. Now, how do you measure this fluid responsiveness in the neonates? It can be measured by the normal monitors such as heart rate, mean arterial pressure, oxygenation, difference between core and peripheral temperature, urine output, capillary refill time, lactate, and the base deficit. But there are certain advanced monitoring techniques. The best static measure in the neonate is the stroke volume index, which is measured by the transesophageal Doppler. And the most useful dynamic measure that predicts fluid responsiveness is the ventilation-induced variation in the aortic flow velocity, which is measured by the transthoracic and the transesophageal echo. Dynamic measures based on arterial pressure waveform analysis and arterial waveform contour lysis, they are not predictive in small infants and neonates. So what are the goals of perioperative fluid is? You should have a good urine output between 1 to 3 ml per kg, allow weight loss of 1 to 2% in the first week of life. There should be no dehydration, but there should also be no signs of edema or hepatomegaly. The urine specific gravity should be between 1.005 to 1.015. Normal glucose should be maintained between 75 to 100 milligram per dl. Normal sodium between 135 to 145 milliequivalent per liter, and normal potassium between 4 to 5 milliequivalent per liter. So to conclude, I would say that understanding of the neonatal physiology is important. Pre-operative fasting should be confined to a minimum hours. Glucose containing fluids are best avoided in elderly children. Restoration of the circulating volume and vital organ perfusion is the first priority in the perioperative fluid management and is best accomplished with an isotonic crystalloid. Replacement of fluid should be based on individual response, and symptomatic hyponatremia and hypokalemia need emergency treatment. These are the references. Thank you.
Thank you, madam. Just like a mother holding the hand of an infant or a boy through the crowded roads, madam has taken us through the...
Excellent.
Dr. Mayank, sir.
Excellent talk, sir. It was a comprehensive coverage of each and everything that we require for pediatric fluid management. Thank you so much for enlightening us, madam. Now we can, sir, with your permission, can we move on to the next topic, sir?
Yes, yes, you have to, sir. You have to go ahead.
Yeah. So can we invite now Yash for the next topic? Yash? Dr. Yash? Till then, we can just see that in pediatrics, how the European guidelines have actually changed the entire scenario of the pediatric culture in the recent years. Don't you think so, sir?
Sir, actually, still the debate is going on regarding this
Yes.
controversies in IV fluid.
Exactly.
I thought we will come at the end for that, because now
Yes,
even
sir.
instead
Sure,
of 4
sure,
to
sir.
2 to 1,
Dr. Yash?
is 1. Yes.
Dr. Yash, are you there?
Yes, yes. He is there, very much there.
Dr. Yash, you start please sharing your screen. Thank you so much, Dr. Yash. It is visible.
Yes, you are muted.
Yes, please unmute yourself and start delivering the lecture. You are not audible, yes. You increase your decibel. Sir, and
Dr. Yash, is there any problem? Yes, you are not audible. Any problem?
I've told somebody to check, Mayank.
Yash, Yash is
Yeah.
not opening his mouth. Or else you can chat. Yes, you are not audible. You just open the chat box and tell us what is the problem. Clear net.
Dr. Yash, if there is any issue, what we can do is you slide the pictures and we can have another person speaking. You speak and somebody else slides.
Oh, he is not audible. Oh. Yes, you are not audible. I think whether your microphone is on. Your microphone.
अरे वाह, ये तो ऐसे ही खुल जाएगा. Dr. Yash, no issues, be cool, आराम से हो जाएगा.
Yes, your video is good. You check your audio. Audio is the problem. Or else you log in through a different device. You don't be upset. I think your face. You ask somebody to have. Now at least you are smiling. See, you are not audible absolutely. Please, you can log in through your mobile.
यश, आप डबल लॉगिन कर लो. लैपटॉप से जो है वो आप स्लाइड्स दिखा दो और मोबाइल से बोल लो.
हाँ, डन. ऐसा ही करना. मोबाइल में लॉगिन करना अभी.
Madam, can you please present the slides otherwise? Or let Aishwarya present it?
Sorry, he has said some network issues. He has said, but he is not ready to settle that, sir. Before that, moderator, sir, I think there are some few questions. You can take it up right now.
We will take a few questions. The
Yeah,
first question is a very interesting question. How to treat hyperglycemia in neonates that usually occurs after surgery when given 10% dextrose?
You can give isotonic fluid, either ringer lactate or normal saline. And that can take, they've said that you can give a bolus of about 10 to 20 ml per kg over 10 minutes and then do the glucose level. I think we can hear him now.
Yes, you are audible now. Next is micro cuff tubes indicated in the neonates?
Aishwarya?
That I think moderator can answer. Why you
Uh,
post
Sir,
that?
at this present moment, yes.
Yes.
Why you torture the
Um, the
postgraduate?
next question is, what fluid is preferred in newborn less than 24 hours? Can we give normal saline as a replacement?
No, you want to give electrolytes only after the postnatal diuresis has occurred. That is after 48 hours, 48 to 72 hours. Then only you give something, any fluid with electrolytes. It is usually 10% dextrose that is indicated.
Yash, you were
Yes.
very good. Chalo, aa jao, aa
Yes,
jao.
sir. So I'm
Aa jao. Good. You can start. Thank you so much.
okay. Good evening, everyone. I'm Dr. Yash Mehta, consultant anesthesiologist at KRCHL Hospital. So our major objectives are to define and classify congenital diaphragmatic hernia, to understand the embryology and pathophysiology of congenital diaphragmatic hernia, and clinical presentation and diagnosis. And after that, we will be discussing about the anesthesia considerations and management portion of CDH patients. So how can we define CDH? CDH is a condition resulting from a developmental defect in the diaphragm leading to protrusion of abdominal contents into the thoracic cavity. The incidence of CDH is approximately 1 to 4 in 10,000 live births. So how can we classify hernias? Bogdelic hernia, which is most commonest form of diaphragmatic hernia. It is the defect in posterior lateral part of diaphragm. Left side is more commoner form of Bogdelic hernia. Now, the second form of hernia is Morgagni hernia, which is very rare. That is up to 10 to 25%. Now, the central hernias are more rarer ones with 2 to 5%. And if defects are present bilaterally on the both side of diaphragm, the prognosis is very poor. So etiology of CDH, etiology is very unclear of CDH patients, but we can consider genetic, environmental, and nutritional factors. It can be associated with multiple syndromes like Pallister-Killian syndrome, French syndromes, and Cornelia-de-Lange syndrome. Multiple chromosomal aberrations and single gene mutations are also responsible. Most frequent aneuploidies like trisomy 18, 13, 21, and Turner syndrome. Now, exposure to teratogenic agents like mycophenolate, mofetil, allopurinol, and lithium are also responsible for CDH. So we will be looking about the embryology of diaphragm. So the formation of diaphragm starts by 5th week of gestation, which completes by 4th month of gestation. So majorly tendinous part of diaphragm is formed by the septum transversum, and two pleuroperitoneal membranes and peripheral body wall muscles form the muscular part of diaphragm. The crura of diaphragm is formed by mesentery of esophagus. In diaphragm, septum transversum is shown by green color, and second number is at the both sides two pleuroperitoneal membranes. The red dot is of peripheral body wall muscle, and the fourth number is of mesentery of esophagus. So pathophysiology of CDH, any disturbance in the formation of pleuroperitoneal membrane can result in diaphragmatic discontinuity. Herniation of abdominal viscera into thoracic cavity can interfere with normal lung development and forms the basis for the two main pathological findings, which are lung hyperplasia and abnormal pulmonary vascular development. So the lung hyperplasia is reflected by a marked decrease in airway generation, terminal bronchioles, and alveoli. Hypoplasia is noted bilaterally, with the lung of the same side is affected more severely than the other one. There is also an abnormal vascular remodeling of pulmonary vasculature, resulting in thickening of arterial walls with the potential to develop persistent pulmonary hypertension, which further results in left ventricular hypoplasia. So the two-hit hypothesis, what does it says? The first hit affects both lungs before the diaphragm develops. Potentially, it may be due to genetical or environmental factors. And second hit is occurs after the diaphragm defect due to herniated abdominal contents. So now we will see the how patient will present clinically and how can we make the diagnosis of patient. Clinically, patient will come with classical triad of respiratory distress, scaphoid abdomen, and a displaced heart. Respiratory distress is a cardinal sign which may appear. Respiratory distress can be soon after birth or may appear by 48 hours of birth. Scaphoid abdomen. Scaphoid abdomen is because of increased chest wall diameter. Bowel sounds can be heard in chest with decreased breath sounds. Apex beat may be displaced. A small group of infants with CDH presents beyond neonatal period with GI upset or mild respiratory symptoms. So we can make diagnosis on USG by 18 to 24th week of gestation. Here USG is shown. It is showing the heart shadow with lung shadows, and we can see that stomach with bowel is protruding towards the thoracic cavity. So visualization of abdominal contents in the thorax and mediastinal shift to contralateral side of the diaphragmatic defect on ultrasound examination are characteristic features of CDH. So somehow right-sided CDH can be missed on USG because echogenicity of liver and lung is very similar. So how can we diagnose the right side of diaphragmatic defect? We can go for a color Doppler ultrasound examination, which helps identify the presence of ductus venosus and intrahepatic vessels in thoracic cavity. So by this, we can diagnose right-sided defect. So diagnosis can be made on fetal MRI. The degree of lung hypoplasia, position of liver, and coexisting anomalies determine the survival chances and prognosis in CDH patients. So that were antenatal diagnosis. Now we will be looking for the postnatal diagnosis. How can we make postnatal diagnosis? So it can be done on chest radiographs. Chest radiographs should be taken with nasogastric tubes in situ. So we can see the tip of nasogastric tube, which is in thorax, which should be in abdominal cavity. So this shows that bowel with stomach, which has been protruded towards the thoracic cavity. So other options for diagnosis after birth are USG chest. We can go for echocardiogram for to rule out congenital heart diseases, renal USG to rule out the genitourinary anomalies, and we can do ABG of patients which shows mixed respiratory and metabolic acidosis with severe hypoxemia and hypercarbia. So we will now be looking for the management of prenatal and postnatal CDH patients. We will be majorly emphasizing on prenatal management of CDH patients. So in 1970, Liggins administered first corticosteroid to fetus to increase the surfactant production in preterm fetuses at the risk for respiratory distress. This was a short history how this prenatal management and fetal intervention started. In prenatal management, we mainly aim, our aim is to interrupt the in utero progression of an otherwise treatable condition. So how can we manage patients prenatally? Prenatally, we can manage medically and surgically. Medical management can be done by antenatal steroids, and we have many options in surgical management, which mainly depends on gestational age of diagnosis. So some of the procedures are exit or OOPS procedure. Exit is ex utero intrapartum treatment, and OOPS is operation on placental support. Now, next procedure is minimal invasive mid gestational procedure like FIGSIT and FET endo. FIGSIT is fetal image guided surgery for intervention and therapy, and FET endo is fetal endoscopy. We can go for mid gestational open surgeries. So, first of all, we will be looking for exit or OOPS procedure. As diagram is showing that this picture is showing that fetus is present in utero connected to placenta, and anesthesiologist is trying to intubate the patient. So yes, this is done in fetuses with non-airway compromise. The exit is an extension of a standard classical cesarean section where an opening is made on the midline of anesthetized mother's abdomen and uterus. Then comes the exit. The baby is partially delivered through the opening but remains attached by its umbilical cord to placenta. Procedures such as endotracheal intubation is done. And once the exit is complete, the umbilical cord is clamped, then cut, and the infant is fully delivered. Then the remainder, after delivery of baby, remainder of C-section proceeds. So the next procedure is mid-gestational, minimal invasive mid-gestational procedures, which is FIGS-IT. The full form of FIGS-IT is fetal image guided surgery for intervention or therapy. As this picture is showing, ultrasound probes are placed on maternal abdomen. We visualize the umbilical veins, umbilical cords and umbilical veins. After that, we have to introduce the spinal needle through transabdominally inside the umbilical vein. We have to introduce corticosteroids after that, which will directly transfer to baby. So this is a very important procedure. So there are many prognostic indicators of fetal CDH outcome. One of them is ultrasound based. What we have to do, we have to take ratio of fetal lung area to head circumference. If the ratio of fetal lung area to head circumference is less than 0.7, the survival chances are very less of these infants. If LHR, which is fetal lung area to head circumference ratio, which is more than 1.4, so the chances of survival are much greater in those infants or fetuses. So our next procedure is FET endo. FET endo is fetal endoscopy. As picture is showing you, multiple trocas are placed in utero to visualize, and fetoscope has been passed through the trocas to visualize the baby. In these procedures, fetal endoscopic surgery using small endoscopic instruments guided by direct fetoscopic camera view and simultaneous real-time ultrasound imaging is done. Fetal endoscopic surgeries is typically accomplished percutaneously, but it may require mini laparotomy sometimes. So the next procedure is FETO. FETO is fetal endoscopic tracheal occlusion. FETO is a minimally invasive procedure where a small balloon is inserted into the fetal trachea to block the airway. Endoscope is used to place a small detachable occlusive balloon in the fetal trachea. After that, fetal continues to grow through the rest of gestation with the reversal of the disease process. Now, after that, balloon is deflated at the term and by second fetal endoscopical surgical technique. What is the importance of feto procedure? It may improve type 2 pneumocyte functions and increase the surfactant production. How feto procedure works? Definitive tracheal occlusion restricts the normal outflow of fetal lung fluid and provides an increase in pulmonary hydrostatic pressure. Due to the tracheal occlusion, what happens? The outflow of trachea is occluded, which causes increase in pulmonary hydrostatic pressure. Because of this increased pressure, it pushes viscera out of the thorax, which promotes the expansion of hypoplastic lung, and thereby it improves lung growth and development. After this procedure, surgical repair is planned postnatally. So this procedure is very important procedure, which is known as fetal endoscopic tracheal occlusion. Next procedure is mid-gestational open surgeries. It involves a maternal laparotomy and hysterotomy. Fetus is exteriorized for procedure, and after the procedure is complete, fetus is placed back into the uterus, which is closed later. The fetus continues to grow through the rest of gestation with the reversal of disease process that prompted the fetal intervention. So in this procedure, first of all, laparotomy or hysterotomy is done. Fetus is exteriorized, and procedures are done over the fetus. After that, after completion of the procedure, fetus is again placed inside the uterus, and we close the uterus, and fetus continues to grow with rest of gestation. So what are the risks of fetal surgeries? Maternal risks are chorioamniotic membrane separation and chorioamnionitis, preterm labor, hemorrhage, pulmonary edema, oligohydramnios, spontaneous labor, hysterotomy site dehiscence, amniotic fluid leak and wound infection. Now, some of the fetal risks are teratogenicity because of the anesthetic drugs, prematurity, intrauterine infection, fetal vascular embolic events, or premature closure of ductus arteriosus, CNS injuries due to maternal hypoxia. So up till now, many questions might have arisen in your minds, which can be like, does fetus experience any pain? Or does fetus remember? Or how can we replace amniotic fluid after procedures? So in upcoming slides, we will be answering these questions now. So the question is, does the fetus experience pain? Fetus are unlikely to experience pain before 24 weeks of gestation, because the cortex requires additional growth and development to establish the extensive neural network of pathways to other CNS structure. So yes, fetal will experience pain after 22 to 24 weeks of gestation. So when does pressure, temperature, and vibration sensations come in fetus? It comes by 6 to 10 weeks. And peripheral sensory nociception is by 10 to 17 weeks of gestation. Reflex withdrawal from a noxious stimuli by 19 weeks of gestation. So next question is, does fetus remember? So the answer is yes. Fetus is capable of forming memories, mainly to sound exposure. It can be of short term from 10 minutes to 4 weeks. It comes by 30 to 32 weeks of gestation. So the next question is, how can we replace amniotic fluid? So amnio infusion is the term given to the procedure of replacement of amniotic fluid. It is done by warm ringer lactate with antibiotics, which is introduced at the rate of 250 to 500 ml of solution over 20 to 30 minutes. We should never exceed 2000 ml, or we can maintain AFI 8 to 12 centimeters. So this diagram is showing the fetus, in utero fetus with transducer and ringal lactates. So we have to monitor for the intrauterine pressure while the procedure, and we have to introduce 250 to 500 ml of solution, which is warm ringal lactate with antibiotics, in 20 to 30 minutes. So what fetal monitoring has to be done? Pre-operatively, we have to monitor for fetal heart rate, umbilical artery flow velocity. Intraoperatively, fetal echocardiography, fetal pulse oximetry, fetal heart monitoring has to be done. Now, USG allows imaging of fetal heart rate, cardiac contractility, cardiac filling, as well as Doppler assessment of umbilical cord flow. Temperature monitoring via maternal core and amniotic fluid temperature has to be done. So, the fetal anesthesia and analgesia. What are major anesthetic goals? So, majorly our goal is prevention of fetal movement, inhibition of circulatory stress response, adequate pain relief, and potentially even fetal amnesia has to be covered. Now, the opioid analgesics can be transferred to the fetus by maternal administration, or we can directly administer drugs, ultrasound guided drugs to intramuscular or intravenously. For invasive procedures, fetal anesthesia can be achieved percutaneously using USG guidance or under direct vision when a hysterectomy is performed. For fetal analgesia, fentanyl intramuscular 20 to 10 mics per kg has to be given. When we administer fentanyl, prophylactically intramuscular atropine 20 mics per kg should be administered to baby. For fetal movements, most common drug which can be used is vecuronium in dose of 0.3 mg per kg intramuscular, or if given IV, the dose is 0.1 to 0.25 mg per kg. So the onset of paralysis occurs within 2 to 5 minutes, which remains for 1 to 2 hours. For minimal invasive procedures, MEC with infiltration of local anesthetic agents can be done. If required, opioids and benzodiazepines can be given to mother. Neuraxial techniques like spinal or epidural can be beneficial in following conditions, like multiple insertion sites are required, need of maternal immobility and comfort, or when mini laparotomy is indicated in patients. For open fetal procedures, full general anesthesia is required. In pre-op period, we have to estimate fetal weight via antenatal USG to aid in weight-based fetal dosing. We can introduce epidural catheter pre-operatively for post-op analgesia. Prophylactic medications like antacid, antiemetics, and tocilitis can be administered before the procedure. Intraoperatively, we have to secure a wide bore IV access. We have to attach all monitors like NIBP, ECG, and pulse oximeter to mother. Left uterine displacement by keeping a wedge below the right hip or left lateral tilt to about 50 degree, which can prevent supine hypotension syndrome. We have to pre-oxygenate for 3 minutes, and rapid sequence induction and intubation has to be done. We have to maintain maternal FiO2 greater than 50% and end-tidal CO2 by 28 to 30 mmHg. Air warmers to maintain maternal normothermia. Weight-based unit dose of atropine and epinephrine should be kept in hand immediately. It should be available immediately for emergent situations. So after the skin incision, high concentrations of volatile anesthetic is started for uterine relaxation. IV nitroglycerin as an infusion or in small boluses is useful to decrease the uterine tone. IV propofol and remifentanil with desflurane at 1.5 mg has provided adequate uterine relaxation. So we can maintain blood pressure by IV phenylephrine and ephedrine. Our main goal is to keep mean arterial pressure within 10% of pre-induction baseline. To keep baby warm, we can irrigate fetus with warm saline. Bloods and fluids should be given very cautiously. IV crystalloid restrictions to less than 2 liters to reduce the risk of pulmonary edema. So we should be very cautious for fluids in mother and both for mother and fetus. IV loading dose of magnesium sulfate 4 to 6 gram over 20 minutes. Once the uterine closure begins, we have to start magnesium sulfate 4 to 6 grams over 20 minutes. When uterine closure starts, at that time we can discontinue other tocolytics like nitroglycerin. We have to monitor for neuromuscular blockade carefully because of magnesium sulfate. We can extubate patient when patient is fully awake. Post-operatively, we have to continue tocolytic therapy with IV nitroglycerin and IV magnesium sulfate for approximately 24 hours or more. Prolonged post-operative uterine relaxations might be required. Invasive monitoring with maternal intraarterial catheter is always recommended when tocolytic therapies like nitroglycerin or magnesium sulfate is given to patient. Additional tocolytics like endomethacin, terbutaline, nifedipine can also be used alternatively to nitroglycerin or magnesium sulfate. While this, we have to monitor uterine activity and fetal heart rate. So now we will see the postnatal management of CDH infants. At birth, infants with CDH should have a nasogastric tube with suction to attain bowel decompression. Big mass ventilation should be avoided in CDH patients. The majority of these infants require intubation in delivery room. Ventilation using a T-piece resuscitator is preferred to avoid high airway pressures. Now, ventilator parameters should be kept with, firstly, if we are initiating ventilator parameters, then rate should be kept at higher rates, which are 40 to 60 breaths per minute, or PEEP should be kept by 3 to 5 centimeters of water, and peak inspiratory pressure should be kept below 25 to 28 centimeters of water. Inhalation of nitric oxide is often used for the management of pulmonary hypertension. For blood pressure management, fluid boluses and vasopressors can be used. In intraoperative management, firstly, we have to stabilize patient medically to improve respiratory and general status of such patients. Perioperative goals are improvement in ventilation and oxygenation. We have to correct acidosis and systemic hypertension. Reversal of persistent pulmonary hypertension can be done with inhaled nitric oxide, sildenafil, or milrinone. So the induction and intubation. We have to pre-oxygenate for 3 minutes and rapid sequence induction has to be done. Inhalational agent sevoflurane can be preferred over other inhalational agents. For blunting stress response, analgesics with opioids should be administered. Bag mask positive pressure ventilation should be avoided till intubation, and nitrous oxide should not be used in such patients. How can we maintain anesthesia? Anesthesia can be maintained on oxygen plus air and inhalational agent. Fentanyl can be given in maintenance. Muscle relaxant should be always given after tracheal intubation. We can prefer NDMAs after tracheal intubation. So what all monitorings which has to be done? Precordial esophageal stethoscope should be used. ECG monitoring, pulse oximetry, capnography, inspiratory pressure should be monitored. We have to monitor for temperature, and estimation of blood loss has to be done. Blood glucose and urine output, this all has to be monitored in such patients. So the monitoring goals are, we should keep PaCO2 between 40 to 55 mmHg. FPO2 should be kept above 85% and pH above 7.2. Minimum FiO2 to target PaO2 more than 150 mmHg, and PEEP can be kept between 3 to 5 centimeters of water. So the fluid management, deficits can be corrected by 4-to-1 rule. Isolate P at the rate of 4 ml per kg per hour multiplied by number of hours. So we can correct it. 50% should be given in first hour, and next 25% in next hour, and 25% in third hour. So maintenance can be done with isolate P at the rate of 4 ml per kg per hour, and third space losses can be corrected with isotonic solution, or even colloids can be used at the rate of 8 ml per kg per hour. In post-operative management, elective ventilation should be planned based upon pre-operative respiratory status. If patient's respiration was compromised before surgery, we have to electively ventilate such patients. And if size of the defect is much bigger, we have to ventilate patient electively, and we have to see for the tension on abdominal wall. So other than that, post-operatively, we have to monitor for the temperature, urine output, and blood glucose. Care of nutrition is must in such patients. Treatment of acidosis and pulmonary hypertension. ECMO may be required in PaO2 if PaO2 is not maintained in patients. Awake extubation is to be done when patient is maintaining PaO2 on minimum FiO2 with adequate respiratory efforts. And high doses of opioids and adequate muscle relaxation are required if patients are kept on ventilator. We can prefer blocks like quadratus lumborum, celiac plexus, and erector spinae for post-op pain management. Even epidural catheters can be placed for post-op pain management. So now we will be looking for conventional mechanical ventilation versus high frequency oscillating ventilation. So which one is better? We will be looking in next few slides. So what is high frequency oscillatory ventilation? It is a rescue maneuver for failed conventional mechanical ventilation. In HFOV, it utilizes dispersion of gases which delivers small tidal volumes for patients with acute respiratory distress. It prevents ventilator-induced lung injury by reducing the risk of volume trauma. So there was earlier a trial was done, which is VICI trial, which compared both of the ventilations conventional mechanical ventilation and HFOV. So they concluded that there is no significant difference in combined outcome of mortality and morbidity between two ventilation groups. But they concluded that other outcomes, including shorter ventilation time and lesser needs of ECMO, favored the conventional ventilation. So we can go for conventional ventilation. So ECMO. The indication of ECMO is failure of conventional ventilation if patient is severely hypoxemic or hypercarbic, if patient is in acidosis or pulmonary hypertension, indications are of ECMO. These are indications of ECMO. What are advantages of ECMO? It eliminates right to left shunting by diversion of 80% of cardiac output. It decreases right ventricular workload due to decreased pulmonary blood flow and pressure. Decreases pulmonary vascular resistance as hypoxia and acidosis are corrected. It helps in growth of hyperplastic lung. Overall survival rate in ECMO treated infants are much higher than other conventional methods. So where ECMO is contraindicated, if weight of the patient is less than 2 kg or before 34 weeks of gestational age, if he is with some bleeding disorder or intraventricular hemorrhage, in such conditions, ECMO is contraindicated. So the take-home message is CDH is associated with higher mortality rate, usually associated with lung hyperplasia and hypertension. Surgical repair is only the treatment of choice. Delay surgery until patient is stable, which is associated with better outcome of patients. HFOV, ECMO, and FETO procedures has improved survival of CDH infants. So these procedures can be done in CDH patients. So these are some references of the presentation. Thank you.
Thank you so much, Dr. Yash. You presented it very nicely. And at the same time, it was a very concise topic, specifically covering up the high frequency oscillatory part, because that is a very important mode of respiration now. And I should appreciate the slides that have also been presented. The topic is now open for discussion, please.
Thank you, sir.
Sir, Mayank sir, it will be
There
only
are
in
few
question
questions.
format. Sir, it will be only in question format. Already 2 questions have to be answered.
Okay, we use Dr. Yash. The question is for you. Should we use cuffed or uncuffed endotracheal tube? What is the modern recommendation? This is by Dr. Jayati Ghosh. Dr. Yash,
Yes, sir.
should we use cuffed or uncuffed endotracheal tube? What is the
Sir,
modern
of course,
recommendation?
cuff tubes are preferred in such age group patients.
Okay.
So
The
we
next
can go
question
for
is why
cuffing.
not atracurium, vicuronium, as long-acting in neonates with immature organ functioning for metabolism? Why can't we use atracurium?
Actually, sir, longer acting drugs are preferred in such patients because elimination of drugs is at much higher rates in younger age groups. So
Okay.
if we will give atracurium, we have to give it in much higher doses and we have to give in much more doses. So
Okay.
vecuronium is much more longer acting drug, so we can go for the drug.
ठीक है. Right.
With this central clearance of drugs are much higher in infants and fetuses. So we have to prefer longer acting drugs over shorter acting.
Okay. Thank you so
Sir,
much. Thank you.
sir, Mayank sir, Dr.
Yes.
Kumar Rajagopalan has asked a question. Is
Mm-hmm.
micro cuff tubes indicated in
Sir, we
neonates?
have already answered this.
Right.
We have already.
Because the moderator has that audibility was a problem. Now I want to ask Madam.
Yes, sir.
Madam, you said because of this controversy evoked. See, now you say the formula is 4:2:1, 10
Yeah.
kg, 20 kg. But now I was told that it is changed to 2:1:1. Which one you follow?
See, in the very small neonates, you follow 2:2:1, while in elder children, you use 4:2:1.
That is right.
Yeah.
Okay. Because that is a continuous controversy. And Dr. Yash,
Yes, sir.
you said the fentanyl dose is 10 to 20 microgram per kg IM.
Yes, sir.
You want to stand on that statement or you want to retract that statement?
No,
10 to
I
20
have gone through
microgram per kg IM. Is it a printing mistake?
Yes,
or,
sir. This is an correct dose. I have gone through many articles which suggest that 10 mics per kg has to be given intramuscularly. IV doses are different. These are intramuscular doses which should be given to the patient, which can be given over deltoid or mid-thigh.
So that we have to check actually, because even intramuscular dose, if it exceeds 5 microgram, it will be a problem. And 10 to 20 microgram per kg per IM is a heavy dose.
Yes, sir. It's an heavy dose, but it is indicated in such age group patients.
So sir can have the wind up discussions. Dr. Mayank sir.
Thank you so much, all the people at the well as Aishwarya. It was a real pleasurable webinar. At the end of the day, we summarized a lot of things specifically related to the neonatal as well as the pediatric age group. And thank you so much, Meenakshi Sundaram sir, for giving us this opportunity to be in academic view as well as at the same time concise a particular topic. And may you continue to do such good academic activities of which we can be a part of. Thank you so much.
Thank you, sir.
Thank you so much to all the audience who actually attended it, and they were very sincere in asking the questions as well. Thank you
Now
so
I
much, sir.
request Dr. Hema, our treasurer, to propose vote of thanks.
Thank you, sir. Good evening, all. Thank you all for participating in today's episode. I thank our academic chairman, Dr. A.L.M. sir, the man behind the Pudukkottai webinar series. I thank the Department of Anesthesiology, CHL Hospital, Indore, Madhya Pradesh. I thank Dr. Aishwarya Pramod, resident, Care Hospital, Indore, Madhya Pradesh. Thank you. I thank Dr. Meenu Chadha, HOD ma'am, Care CHL Hospital, Indore, Madhya Pradesh, for the presentation on perioperative fluid therapy newborn. Thank you, ma'am. I thank Dr. Yash Mehta, consultant, Care CHL Hospital, Indore, Madhya Pradesh, on the presentation on anesthetic management on congenital diaphragmatic area. Thank you. I thank our moderator, Dr. Mayank Massand, sir, senior consultant, Visesh Jupiter Hospital, Indore, Madhya Pradesh. Thank you, Clarinet, for your continuous support. I thank all the participant consultants for participation in today's episode at short notice in the change of time. Thank you all. Good evening.
I request Clarinet to pass the concluding remarks and close the session.
Yes, thank you so much, everyone, for joining. It was a very informative session, and Clarinet is really glad to have all these brilliant people together. So, with all your permission, I'm closing the session over here.
Thank you. Thank you all.
Thank you, Dr. Meenakshi. Thank you once
sir.
again.
Thank you, sir. Thank you.
Thank you so much, all. Thank you so
Thank
much.
you.
It was
Thank
a
you, sir.
pleasure.
Thank you.
Thank you. Thank you so much, sir.